Welcome. I'm Carl Svedberg from the University of Gothenburg and Imperial College in London. This is EHJ Video Today. I'm here at the ESC in Barcelona, and with me today is Professor Fayez Sanad from the University of Lorraine in Nancy, France, and Professor Cecilia Linde from the Karolinska Institute in Stockholm. Fayez Sanad has presented an interesting study, NECTAR, today. Fayez, our audience is probably not very familiar with neither the NECTAR or the technique that you have used. Can you give me a review of the background to the study?
Yes, with a pleasure. NECTAR is essentially a trial of the vagal stimulation, the vagal nerve. It's based on the hypothesis that vagal tone is decreased in heart failure, and this is reciprocated by an increase in the sympathetic tone. We have quite a few therapies which decrease the sympathetic tone, and pumping up and increasing the vagal tone was problematic, and we didn't have a therapy so far. So electrical therapy with vagal stimulation could be a solution, and this had been tested in animals, and in the dog model of heart failure, vagal stimulation was very effective in shrinking the heart, decreasing BNP, and also actively improving the various mechanistic pathways of heart failure. So this was the background, physiology, pathophysiology, and basic science experimental model testing.
Sounds really as a new option for patients in heart failure to address the autonomic imbalance. So what did you do in this trial?
Yeah, I would like just to mention that this was one among other therapy addressing the autonomic nervous system. There is the renal denervation, baroreflex stimulation, and spinal cord stimulation. So this was actually the first randomized, controlled, sham-controlled trial into this area of autonomic nervous modulation. And it should be taken as such: proof of concept, feasibility, first controlled sham. What we have done is we have screened patients with low ejection fraction, mild moderate symptomatic heart failure, class 2 and 3, and willing to participate in the study. There was quite a few exclusion criteria, mainly related to dysautonomy, obviously diabetes with long-standing diabetes, for example. And these patients were randomized, all implanted first, and then recovery during 2 weeks. And after this recovery, patients were randomized. After baseline characterization, randomized, 2/3 of the patient received therapy on, and 1/3 received the sham operation with no stimulation. So in total, we started with 96 patients randomized to 2/3 and 1/3 of sham control. And then we delivered stimulation blinded in the two groups. And this is an important point. The therapy is censored by the patient. When the patient are implanted, this is typical vascular surgery. Actually, there is no vascular surgery in itself. It's just in the neck, accessing the carotid, the vagal nerve, and then wrapping it up in the lead and connected to a generator. Simple surgery. By the way, this surgery and this technique is being used in neurology for treating of epilepsy. This is routine. There are thousands of patients who are having this therapy in epilepsy. So that the surgeon who delivered this implantation, majority of them were vascular surgeons, but in some centers these were neurosurgeons. So after the implantation and recovery, patients were randomized. And the stimulation was up-titrated and could be felt by the patient whenever the intensity is increased. It is felt by the patient as a tickling in the larynx, or hoarseness of voice, or tickling in the neck, or vibration in the neck. So when the patient sensed this, we stopped short of this intensity until the next time for up titration. And because there is a tolerance for these signs, we could increase the dose in the on therapy. In the off therapy, after up titration, we stop the stimulation and patient were not stimulating anymore. So this is how we got to a maximum intensity about 1.5 on average.
Okay, and then you followed them for how long, and what did you find?
So the follow-up was short, 6 month randomization, and this was the first period for efficacy. Then all patients are switched on for a safety period of extension of 18 months. The primary endpoint at 6 month efficacy was left ventricular systolic diameter, and this finding was neutral. There was no effect in the sham and no effect on the active therapy group. We have explored a number of other remodeling measurements, and these were all consistent, no effect on ejection fraction and systolic or end-diastolic volume, and consistently show no change in NT-proBNP, no change in peak VO2. So it's a kind of disappointment. We did explore signs and symptoms, and we explored New York Heart Association and Minnesota Living with Heart Failure questionnaire and another quality of life questionnaire, SF-36. Well, these were positive, and we had an improvement, and patient felt better. And this was statistically significant. There were fewer more patients improving with their New York Heart class in the active therapy group. So how to interpret this? It is tricky. Potentially, these are the softest endpoints, subjective, not consistent with the harder endpoint of remodeling. And because of the blinding issue, lots of patients sensed that they were receiving therapy. We actually have done the blinding test, and we asked the patient at 6 months which group they guess they are in. And the majority of them guessed right.
Whatever you did, these patients felt better compared to the control group. If that what that was caused by is another discussion. Cecilia, how do you interpret these results?
Well, first of all, this is a very important study because we all know that on top of drug therapy, device therapy such as CRT may do a tremendous benefit. But not all patients are eligible for CRT, so this is why vagal nerve stimulation could be an attractive alternative if it would work. So my question to you really, Faiz, is do you think that the vagal stimulation was delivered in the proper way? Is it something about how it was, because it does differ a little bit from the Innovate concept where there is an intracardiac lead and RSense therapy delivery?
It is definitely the number one question. Were we delivering enough current, the right stimulation protocol? The protocol is sophisticated, that there are various variables, the frequency, the intensity, but the protocol which the sponsor came up have been tested in animals, and they were quite confident that this did deliver the right stimulation. But now that we have got these results, we may certainly question this and whether other intensities such as being used in other protocols or other techniques, because we elected to stimulate the right carotid, right vagal nerve and only afferent. So efferent, I'm sorry. So there is fine-tuning of technique which should be found out, and there is an intense discussion within the sponsor right now and into this area whether it is worth exploring other methods of stimulations.
For example, you did not see any heart rate lowering.
This is a very good question. The sponsor has elected to have this dose and technique of measurement which is not heart rate lowering. So the finding that the heart rate was not lowered was not much unexpected in this protocol.
So what is next? Is the question, or does this pilot answer what your questions, or what's happening?
I do believe there is really a future of this therapy because the background is very sound, the rationale is very sound. So as much as any new therapy, it needs fine-tuning, and we need to find out the right stimulation protocol, the right intensity, and possibly the right surrogate. Before embarking in larger trials, we may need to find out whether we are actually delivering vagal modulation. And there are techniques which allow to measure vagal nerve and sympathetic traffic and baroreflex sensitivity. So maybe we should also have surrogate endpoints to start with in order to find out the dose fine-tuning. Currently, we need to mention that there is the Innovate trial, which is a totally different stimulation protocol, which is vagal stimulation, and it is a morbidity mortality trial, which is ongoing. So we will learn more from this trial, but certainly meanwhile, before the trial delivers, there would be certainly more refinement to find out and more research to be conducted.
So there is more to come. Cecilia, what's your what do you think about the future with this technique?
Well, I totally agree with Faiz. You have to fine-tune the concepts and know that you're delivering what you want to deliver. But I have another question to you, Faiz, about what about those thousands of epileptical patients? What about their cardiac function? Did you look into that? Because they are there as a potential study group.
Well, this is a brilliant question. We have tapped into this database only to find out about safety. I really don't know what is their future when it comes to heart failure. Epilepsy patients tend to be younger patients, so they're unlikely to be at risk of developing heart failure, but it's worth looking at.
Okay, so thank you. So at present, this is a technique that needs further understanding, and there is a need for more studies before it can apply it in clinical practice, as far as I understand it. Thank you.